Hello, this is Dr. Catlin. I'm going to record the lecture for DIC, or Disseminated Intravascular Coagulation, which is Module 16E in your Pearson. So first, what is DIC? It's when the hemostasis is all out of whack. There is clotting and bleeding throughout the system. It can be acute and life-threatening or relatively mild. It is often due to some traumatic injury or a significant infection such as sepsis that triggers inappropriate clotting and a whole cascade. That's terrible. Your text on page 1223, box 1613, has multiple conditions that can precipitate it: trauma, burns, gunshot wounds, frostbite, head injury, obstetric complications, septic abortion, abrupto placentae, which I believe you probably studied that in OB, amniotic fluid embolus, retained dead fetus, neoplasms, acute leukemia, adenocarcinoma, multiple cancers I know have led to it, hemolysis, fat embolism, aortic aneurysm, acute glomerulonephritis, hemolytic uremic syndrome, bacterial infection or sepsis, viral mycotic infections, malaria. I want you to focus more on the trauma, sepsis, OB complications. We'll talk about fat embolisms for our purposes. So the coagulation process, let's do a little review on this. I know we've been over it and you've heard it in the past. The coagulation is the process of changing the circulating substances in the blood into a gel to plug the leaking vessel. The process is used by the body to form a strong patch, cascade. Blood plasma has proteins that act in the cascade of enzyme events to form a fibrin clot. All the way down here, you need fibrinogen, prothrombin, tissue thromboplastin or tissue factor, and ionized calcium. Calcium is used throughout the process in multiple things. So if you see here, you have extrinsic and intrinsic pathways. The extrinsic over here says tissue factor because it is triggered by tissue injury. So your extrinsic is damage to tissue that leads this process. The platelets in the injured tissue release thromboplastin, which initiates a formation of prothrombinase in the blood. With calcium, this causes it to, calcium ions convert this inactive protein into an active protein right here called thrombin, or prothrombin into thrombin. So, sorry about that. The thrombin converts soluble fibrinogen over here into an insoluble fibrin, so it cannot dissolve. The fibrin enmeshes platelets, blood cells, and plasma, and it forms a clot. You have your intrinsic pathway, which says contact activation. Some kind of trauma inside the vascular system or contact with the artificial surface. So if you look at your box, something would be the vessel damage, like aortic aneurysm, acute glomerulonephritis, hemolytic uremic syndrome. It also can happen from putting in a stent. Why somebody with the stent for a long period of time will be on antiplatelet or anti-clotting to decrease the intrinsic pathway for DIC. So the clotting factors that are in there, I'm just going to go over exactly what they are. So your tissue factor, if I go back here, your tissue factor. It is a protein found on the surface of some body cells. And then you have your prothrombin right here, factor 2. It's a glycoprotein present in the plasma that is converted into thrombin, here to here, from the extrinsic thromboplastin during the second stage of blood clotting, or factor 2. Factor 2 prothrombin converting. And then your thrombin here. The activated form of prothrombin, factor 2, becomes thrombin. Factor 11A, and to form your fibrinogen, and then the fibrinogen, which is your next on your list. Fibrinogen is a high molecular weight protein in the blood plasma that by the action of thrombin is converted to fibrin or factor 1. Then you have fibrinolysis, or fibrin, insoluble protein end product of blood coagulation, formed from fibrinogen by the action of thrombin in the presence of calcium. The fibrin threads a meshwork to form a blood clot, and then you have your fibrinolysis, which is a process the body uses to break down a clot. So you have a clot. Fibrinolysis is another term. When we get, is it in DIC? No, when we get to pulmonary embolism, when we talk about the different things, they work on the different factors here. So we talk about factor 1A, it stops here, blocks the fibrin 1A, so you cannot form a clot. Okay, enough on that page. So, your clot formation, the balance of coagulation. The damage can be from tissue damage, vessel damage, infection. Most common are severe sepsis and septic shock. The excess thrombin within the circulation overwhelms the naturally occurrent coagulants. See, excess thrombin here. Widespread clotting occurs because conversion of plasminogen. No. Excess thrombin, microvascular clotting, thrombocytopenia. So all this excess clotting consumes all your clotting factors. Fibrinolysis, which is the breakdown of the clots with excess fibrinogen. And then you have the excess clotting and the bleeding. So the excess clotting causes ischemia, multi-system organ difficulties, and organ damage. The excess bleeding, you have hypovolemia, so you have a hemorrhagic and a hypovolemic shock, hypotension, and then the vasculature, it becomes very permeable. See, I'm trying to look at my notes, see if there's anything else I need to tell you there. The clotting factors of platelets are used faster than they can be produced. This fibrinolytic process is trying to break down these clots, which leads to excess clots. The body's trying to help itself, but it's not. This that's what FDP is, fibrin degradation products. They're very, very strong anticoagulants, which are released in the part of this fibrinolysis process, leading again to further bleeding. Okay, next slide. Risk factors, multiple risk factors, page 1223 and 1224 list the factors, hemolytic reactions to blood transfusions. Hemolytic meaning it's a reaction that occurs in the blood and causes this DIC. Bacterial or fungal blood infections, like I said, often it's a sepsis. A large hemangioma, certain types of leukemia, pancreatitis, liver disease, recent surgery, anesthesia, severe tissue damage, such as burns and head injury, significant trauma, and complications from pregnancy. Your clinical manifestations, they are due to both the clotting and the bleeding, which is happening both internally and externally. We are, for our purposes, are going to focus on the manifestations of acute DIC, even though it can be chronic. Usually chronic is due to a cancer and clotting, but not so much due. The chronic, often due to cancer, causes clotting and minimal, if any, bleeding. It is a very slow process and difficult to identify, where the acute is a sudden onset. So your cardiovascular, you're going to have tachycardia, hypotension, circulatory collapse, and major vessel thrombosis. If you look on page 1224, your manifestations with this cardiovascular are your decreased perfusion, shock, inappropriate clotting, tissue necrosis, gangrene, oozing from wounds. You have to replace the lost fluids, closely monitor INO, watch their vital signs, and obviously maintain bed rest. Their respiratory system, you're going to see tachypnea, decreased breath sounds, possible pleural friction rub, and they can go into ARDS. There's clots throughout the pulmonary vasculature impeding your oxygen gas exchange, and you're going to maintain their ventilatory status. CNS or central nervous system, confusion, coma, seizures, focal deficits. There is impaired in all body systems, so there's impaired perfusion into the cerebral. You're going to do neuro checks, minimum of every 2 hours. When they're very acute, you might be doing every 15 minutes to 30-minute checks on them. Your urinary system is evident through oligoria, anuria, renal failure, possible hematuria because they're bleeding everywhere. There's going to be impaired renal perfusion, as I said, multi-organ system failure, I guess. You're monitoring your INO, watching for hematuria and clotting, and making sure that the catheter is not clotted, or that their bladder, if they don't have a catheter, the bladder is not distended, because they can form clots and obstruct urinary flow also. So your GI bleeding, abdominal distension, remember watching your girth, bleeding from the mucous membranes. You might have occult blood or frank blood in the stools or emesis. You're every 2 to 4 hours measuring the abdominal girth. Integumentary, petechiae, purpura, ecchymosis, bleeding or oozing from wounds or IV sites, obviously pallor, cool extremities, cyanosis of extremities, because they're just going to bleed everywhere from everything. So you're monitoring their skin, all their sites. You're protecting them from injury in any way you can, monitoring their pulses, temperature, capillary refill. Your labs, your complete blood count, you're watching your hemoglobin, hematocrit, and platelets. Your they also might do a smear on your CBC because they're looking for schistocytes, which is fragmented or broken red blood cells. Coagulation studies are your PT and PTT, which will both be elevated. Your D-dimer, which is your fibrinogen degradation product. We will be talking about D-dimer when we talk about pulmonary embolus. The D-dimer is elevated from this FDP, which I mentioned earlier, the fibrin degradation product. That's when clots are broken up by fibrinolysis. This fibrin degradation product is evident in the blood. You're making a positive or elevated D-dimer. And your fibrinogen level in DIC is low. So what do? Giving them Your goal is to restore the clotting factors in platelets and control or alleviate the organ damage. Part of organ damage is the blood clotting, clots going to it. Some is because of hypoperfusion, because of decreased volume. So you're going to give fresh frozen plasma. It has all factors of soluble coagulation system. So all those coagulation products that have been used up, fresh frozen is to replace it. It can be used when they're active bleeding or very much at risk for bleeding. It does have to be cross-matched. So fresh frozen does have to be cross-matched. Your cryoprecipitate contains a subset of your fresh frozen plasma, but it also includes fibrinogen, factor VIII coagulant, von Willebrand factor, and factor VIII. It's indicated for the treatment of fibrinogen deficiency. When there's clinical bleeding and they have to do an invasive procedure, or if there's a trauma, they're in DIC. For cryoprecipitate, you do not have to cross-match. Then you have your platelets. You will transfuse your platelets again to replace the non-functioning or loss of platelets. Heparin is controversial. If it's used, usually it's low molecular weight heparin. That is used to be used right away in DIC. It no longer is. If it's used, it's usually in the chronic, not the acute DIC, because you remember the chronic has the clotting, not so much the bleeding. And then your non-pharmacological is supportive care, ventilation, and anything you can do to prevent further organ damage or lessen organ damage. So infants and children, newborns that are increased risk of bleeding disorders, the risk factors are if they're born with deficiencies in the coagulation factors, a birth trauma, asphyxia, necrotizing enterocolitis, starts in the gut, and obviously sepsis. Newborns are greater risk due to their natural deficiencies when they're first born. They can have blood oozing from the umbilicus around their circumcision. Look for birth-related bruising or others. When you don't have, distinguish between birth-related bruising and bruising with no explanation. Older children have risk factors when there's endothelial damage, hypoxia, acidosis, or shock. Congenital heart disease, rickettsia, they usually present with headaches, lightheadedness, nosebleeds, bleeding gums, blood in the urine and stool, and they are treated the same as an adult. Pregnant women, going to touch on this because you guys are getting ready for NCLEX. Changes in the hemostatic mechanism due to pregnancy put them at increased risk for acute DIC. They have a decrease in the natural anticoagulants because of the pregnancy state and preparing for delivery. They will usually present with ecchymosis, mucosal oozing, bleeding of the GI tract, maybe some bleeding at their incision sites. Increased risk if they experience preeclampsia, fetal death, amniotic fluid embolism, and septic abortion. I put on there the HELP syndrome, which you learned in OB. Your treatment is the replacement of blood and blood products, and they may use some anticoagulants. Management of the major obstetric bleeding like any other trauma patient. Nursing process, focused on care. Focus of care is on assessing the bleeding, preventing further injury, and administering prescribed therapies. Continuous assessment of the entire body, all body systems. Check dependent areas that that might be underneath that aren't visible for bleeding. Maintain their skin integrity. Assist the family and the patient with coping. You're assessing for petechiae, ecchymosis, and oozing every 1 to 2 hours, IV sites every 15 minutes, anywhere where there's invasive line. Again, the dependent areas because of blood pooling, check on your urine and blood, urine and stool for blood, measuring blood loss, monitoring vital signs, and continually assessing their level of consciousness. When you're doing the patient interview, recent medical history, any blood transfusions, recent trauma, if they're currently pregnant, did they have a recent abortion, elective or non-elective, any known malignancies, recent treatment for malignancies, history of abnormal bleeding, exposure to infectious diseases, if they're having problems with nosebleeds, bleeding gums, bruising, ecchymosis. Again, your physical assessment, your vital signs, auscultation of your heart and lungs, inspection of skin, abdomen, possibly abdominal girth, looking at all invasive sites, monitoring O2 sat, looking for blood in urine, ABGs, airway, gentle repositioning. I mentioned abdominal girth, your abdominal assessment, also looking for abdominal distension, guarding, or tenderness. Diagnosis and planning, ineffective peripheral tissue perfusion, impaired gas exchange, acute pain, and fear. You want them to have increased vascular volume, maintain adequate gas exchange, adequate pain control, early recognition of illness progression. Promote effective tissue perfusion, assess extremities for warmth, strength, capillary refill, level of consciousness, repositioning every 2 hours, discouraging leg crossing. Do not elevate at the knee of the bed because you obstruct blood flow that way. Minimize use of tape on the skin because of promoting tissue perfusion and intactness. Monitor gas exchange, O2 sats, high Fowler's position if tolerated, bed rest, deep breathing, coughing, nasotracheal suction. If you need to do it with caution because of the risk of bleeding in the airway from doing that. You want to give analgesics. Often it is morphine that is given, anti-anxiety medications if they're ordered, because this is a very significant state to be in. Managing their pain, cool compresses to painful joints. You don't want warm because you don't want to increase blood flow. The painful joints are usually due to bleeding, and the cool compress is to suppress that bleeding into that joint. Evaluation, your goals are for no long-term complications, effective coping mechanisms of patient and family, controlling the bleeding, and no body system deficits, so perfusion is good. And that is the end of this recording.